All right. Well, as we get started the year with the ultrasound presentations for the sports medicine fellows, just wanted to give a quick reminder about the AMSSM Library of Sports ultrasound pathology. So this is a really great opportunity to take ultrasound pathology you've seen in clinic, the training room, or the sideline, and actually turn it into a peer-reviewed publication to add to your CV. For this, they're looking for both common and uncommon, pathologies. So it does not have to be like an extreme, atypical or zebra case. Just remember that. And so both residents, fellows, and attendings are all encouraged to add to this growing collection of cases, which is a really great resource if you haven't gone to it through the AMSSM. So there is a QR code here that you can reach out. Otherwise, if you go to the AMSSM ultrasound page, you also see information on who to reach out to for this. And just on a personal note, I've done two of these cases and just been, very fortunate and worthwhile, process for me going through this. A very enjoyable process, and so definitely, would plug these, especially if you do have a training that is looking for like a peer reviewed, publication through this organization. Otherwise, I have the pleasure to introduce today Dr. Devon Shannon. So he's a primary care sports medicine fellow at Emory University. He completed his medical school at the University of Toledo College of Medicine and then his residency in PM&R at Vanderbilt. And then he currently serves as the fellow associate chair for the AMSSM Sports Ultrasound Case Series. And today he's going to be giving us a talk on PIN syndrome.
Great. Well, thank you again, Dr. Schaff. Great to be here this morning and kick off kind of the fellow portion of the ultrasound case series. So again, I'll be giving this case on posterior interosseous nerve syndrome. So we'll kind of walk through this here. So just an outline of the presentation. So we'll go through the case. We'll talk about some scan considerations, go through the ultrasound protocol for the lateral elbow, get through the images, go over our ultrasound report, and then any take-home points from this case. So our case here involves a 46-year-old right-hand dominant male. He was an artist, does more large mural type art. He was presenting with right dorsal forearm pain, which was radiating down the arm into the dorsal hand. He also noted some subjective weakness in wrist extension, as well as some intermittent paresthesias on the dorsal aspect of the thumb. He felt like maybe this coincided several weeks prior. He was doing lifting of some heavier objects for work, using a sander with a lot of pronation activity for a work project. So on his exam, he had no tenderness over the lateral epicondyle, felt like he had full range of motion of the elbow. He had intact sensation, a light touch in the entire right upper extremity, even in the hand, despite his intermittent paresthesias he reported. He did have weakness in both wrist extension and digit extension on that right side compared to the left, about 4 out of 5. Otherwise, he had full strength in that right upper extremity. He did have a positive Tinel at the radial tunnel as well. So that Tinel really reproduced more of the pain, radiating pain in the dorsal aspect of the forearm. Didn't really reproduce much of the paresthesias though. So I think important when we're considering a scan of the lateral elbow or a scan of any structure to keep in mind what our differential diagnosis would be. So common things being common for lateral elbow pain, thinking about lateral epicondylopathy, tennis elbow, really keeping that in mind, kind of more at the top of differential. This coincided with increased activity of the arm. Did he just strain a muscle there? And then with the radiating symptoms and some vague paresthesias, you also want to keep in mind any nerve pathologies. So that's where you get into our radial tunnel syndrome or PAN syndrome, which we'll distinguish as we go through this case. But also don't want to miss a cervical radiculopathy. So in this case, going down to the thumb, thinking about like a C6 radic. And then kind of keeping a broad differential with some wrist weakness, focal weakness anywhere, even though it'd be less common with the pain that he was experiencing, keeping in mind like a neuromuscular disorder or something along those lines. So when we think about our scan for the lateral elbow, patient position is important. I prefer to have the patient supine. I think it just relaxes them a little bit more. You can kind of move their arm a little bit easier that way. But you can also do this seated. You want the forearm pronated, the elbow in slight flexion. In our image, and when we go through the scan, if you look at the top right corner of the screen, we'll kind of have the transducer orientation on the elbow, so you can follow along with that. Transducer use, you're going to want to use a mid-frequency linear array transducer. But you can consider a higher frequency small footprint transducer. That can be nice when you're trying to look at smaller structures like the nerves, like the radial nerves. So you could switch between the two if needed. And then I think, this scan is going to be focusing on the nerve. So important to keep in mind when you're scanning a nerve, really quick sweeps of the transducer can help you identify the nerve from the surrounding structures around it because it will move a little bit differently than those. When we think about our lateral elbow ultrasound protocol, really the required elements, which we'll go through step by step in our protocol, but also some optional things here. Since we're thinking about the nerve structures here, we did add in the superficial radial nerve through the forearm. Didn't extend all the way down to the wrist, but we watched it as it traveled through the forearm. And then I think an easy one to add on too is the annular ligament, just because it does blend with that radial collateral ligament. So before we get into the scan, important to keep in mind our anatomy. That common extensor tendon is made up of the ECRB, the EDC, EDM, and the ECU. So I think important to really keep that in mind when we're scanning through there, knowing that most of our pathology for lateral epicondylitis or tenosynovial is going to be in that ECRB. So knowing that sits a little more medial or anteriorly is important to keep in mind. And then knowing that the ECRL is going to branch off more on that lateral supracondylar ridge of the humerus, so more proximal, and then even the brachioradialis even more proximal to that. When we think about our nerve as it comes down through the forearm, the radial nerve is going to split between the superficial branch and the deep branch of the radial nerve. That's happening within the radial tunnel. The radial tunnel is a 5 centimeter distance from the radiocapitellar joint as it travels down to the distal aspect of the supinator, bordered medially by the biceps and the brachialis and laterally by the brachioradialis. That kind of is the track of what the radial tunnel is and where that deep branch of the radial nerve travels, and then eventually will become the posterior interosseous nerve as it enters the supinator. So getting to our scan now. So our home base for the lateral elbow scan is going to be having that lateral epicondyle in view. So in a long axis to the lateral epicondyle with the radiocapitellar joint in view and that common extensor tendon in view as well. So that's kind of our home base. So whenever you get lost or not, you can come back to this and scan from there. So first structure, I think easiest to start at is kind of more proximal at that lateral epicondyle is going to be that common extensor tendon. So you want to evaluate that in long axis, ensuring that you sweep, again, like we talked about, all the way medial or anterior and lateral posterior, the full breadth of the tendon. So you're evaluating all of the tendon throughout its course, looking for any hypoechoic changes at its attachment site, any calcifications and thesophytes, any evidence of partial tearing. You can also turn on some Doppler in this area, see if there's any increased hypervascularity, to see if there's any abnormality of that tendon. So we always want to look at structures in two orthogonal planes. So you want to flip and look at this in short axis on the lateral epicondyle. Again, keeping in mind that when we look at this tendon, it's made this common extensor tendon. It has 3 tendon bundles. So that more lateral or ulnar aspect is going to be your ECU, and then the more medial or radial aspect is going to be that ECRB. So looking for any focal defects in the tendon at this area in short axis, confirming what you saw on long axis view. Moving along, next structure I think is easiest to kind of identify is a radial collateral ligament. So this is actually the deeper or inferior fibers to the common extensor tendon off of the lateral epicondyle. Sometimes it can be difficult to distinguish that the radial collateral ligament from the common extensor tendon, but knowing that it's kind of the deep 30% to 50% of those fibers is helpful. I think in this view, we can see a little bit easier with the lateral epicondyle to the left, common extensor tendon, and radial collateral ligament being that inferior portion. You can see a little bit of the fiber direction change as it comes up that way. And the radial collateral ligament will then blend with the annular ligament as it comes over top of the radial head here. You can assess the radial collateral ligament stability with varus stress testing, similarly to how we do with the UCL in a medial scan. And again, applying some dynamic stress at area, looking for any gapping of that joint or laxity within that ligament. Moving just a little bit distally now. Now we're going to be over the radiocapitellar joint itself. So we want to evaluate for any effusion or joint irregularities in this area. So we have our lateral epicondyle capitellum and our radial head, the radiocapitellar joint sitting in between there. You can also look for what's called a lateral synovial fringe, which is essentially a hyperechoic synovial fold that sits within the joint. That can be a normal finding. It can also cause impingement. So if you're worried about any impingement type signs, you can assess for that and look at that dynamically with some pronation supination of the arm or some flexion extension as well. See if that causes any impingement within the radiocapitellar joint. Now, it's difficult to see the hyaline cartilage of the capitellum in this lateral aspect of the radiocapitellar joint. So if you wanted to assess for that, you really want to move the transducer more to the anterior elbow. This is something that we typically see in our anterior elbow scan. But in this view, you can see that hyaline cartilage a lot easier on the capitellum, so you can evaluate that as well. And then again, seeing the radial fossa here more in that anterior elbow type scan. Moving again a little more distally, we'll be over the radial head and the annular ligament. So in this view, you want to evaluate in long axis, looking at the radial head, looking for any cortical irregularities, look for any fractures or anything. You also want to look at that annular ligament as it comes over top of the radial head. Again, this is a view where you can dynamically look at the radial head with supination and pronation to really see the full breadth of that radial head. This is long axis to the radial head, but really you'll be more short axis to the annular ligament as it'd be coming towards us on the screen. So again, you want to look at this in two orthogonal planes. So you can look at that radial head again and the annular ligament, which would be more long axis to the annular ligament in this view. Moving along, we'll get to our brachioradialis. So the origin of the brachioradialis, like that we talked about before, is more on kind of the mid-humerus. So you want to be more proximal than you would think to identify the origin of this. Sometimes it's easier to start in the anterior elbow and trace it more proximally to find this. But you can start here at the mid-humerus and look for it here. You can see the triceps posteriorly, the radial nerve, and the brachioradialis coming off that mid-humerus. We can also look at the brachioradialis a little further down into the forearm. So sitting here, we can see the radial nerve beneath it and the brachioradialis sitting on top in this short axis view. So again, you can look at this in long axis as well. So looking proximally to the left of the screen, you can see the humerus and the brachioradialis coming from that area as well. The extensor carpi radialis longus is going to originate after the brachioradialis. So really to find this, you want to follow that brachioradialis from mid-humerus down. And then you'll see the ECRL originate from the lateral supracondylar ridge as you're doing that. So I have a video of what this looks like, so we'll walk through that here. So as you slide that transducer down distally, you can see that brachioradialis will start to fall away and that ECRL will come into view. So I'll play that one more time so you can see that here. So as that brachioradialis is coming down, the ECRL will start to come out. You can see the morphology change of that humerus there, where you're more on that lateral supracondylar ridge. So there's that ECRL there. And again, you can flip into more of a long axis view and see that coming off of the lateral supracondylar ridge, the ECRL there. So now getting to kind of the bulk of the presentation, going through the radial nerve. So you can identify the radial nerve. We already saw it already at the mid-humerus when we're looking at the brachioradialis. Another easier place to find this is more at the anterior elbow. So if you're more comfortable identifying the nerve there, you can find it at the anterior elbow and trace proximally, or you can start proximally and trace distally. So I wanted to show what it looks like here more at the anterior elbow scan. So you have your joint space there, you have your brachialis and your brachioradialis, with your radial nerve sitting in between those two muscle bellies. Again, if we go more proximal with this, we see the humerus. Now we're at the mid-humerus. You have the humerus here and the radial nerve sitting just next to that, with the triceps going to be more lateral posterior in this view. Starting back at our home base, so that kind of that anterior elbow scan, we want to then trace the radial nerve as it heads into the forearm, where we'll start to see its bifurcation into the superficial and deep branches of the radial nerve. So as we slide this down, we'll start to see that split. So we're still here now at the forearm. We're looking at our brachialis, which is going to be on top of the nerve. And we have our deep and our superficial branches of the radial nerve. So you can see a little bit of that change here. You can see a little septum in between. It's our deep and our superficial branches of the radial nerve. As we travel again a little more distally into the forearm, we can see this split even more. So again, here we're going to have our deep branch of the radial nerve, our superficial branch as it's heading more up into the forearm. And then these other structures here are going to be more of our radial recurrent vessels. So the radial recurrent artery and vein as they kind of pass over this area. So in this view, your deep branch of the radial nerve is starting to head under the arcata frosch and will start to head into the supinator, where it will become the posterior interosseous nerve. So that's kind of the next step in this scan. As we keep going here, you'll see the posterior interosseous nerve as it travels in between the two heads of the supinator after it passes through the arcata frosch. So here you have the ulnar head of the supinator, which is deep, the superficial or humeral head of the supinator, and you have your posterior interosseous nerve sitting in between those two bellies of the supinator. So again, after it passes under the arcata frosch, that's when the deep branch of the radial nerve becomes the posterior interosseous nerve. So you can also evaluate this in long axis view. So if you flip just fine movements of the transducer, just because the course within the heads of the supinator can be variable in individuals, you really want to make sure that you're still honing this in the middle of the screen. So in this view, we can see the ulnar head below it, and you can see the PIN and long axis on top as it's starting to head through that supinator muscle belly. So now I want to go through a couple of videos, just watching the course of the nerve. Again, I think this is the benefit of ultrasound live scanning, is you can really assess this nerve dynamically and really see the course as you're going through, and really helps you distinguish where that nerve is heading and really get a good appreciation of the course of the nerve. So I'll play through this first video. It's going to be the radial nerve at the humerus down to its split between the superficial and deep branches of the radial nerve. So I'll let it play once and then we'll walk through it. So again, that's kind of your transducer as it goes down. As we scan down distally, you can see it start to split. So I'll kind of come back to the beginning of this. So we have our nerve at the humerus. As we start to come down, we see that nerve come, and we're still traveling underneath the brachioradialis at this view. And then as we get a little bit further into the forearm, you start to see the separation beginning between the deep branch and the superficial branch of the radial nerve. And then as we come even more distally, you can start to see that separation there between deep branch and the superficial branch. And then that deep branch is going to start to head into the supinator as it goes under the arcata frosch, and the superficial branch will stay just outside of that. Our next video here is going to be watching that deep branch of the radial nerve as it goes into the supinator. So toggle a little bit with that, and then you see it head into the supinator there. So again, we have as we come down this way, we have our deep branch and our superficial branch, and you can watch that deep branch head under the arcata frosch right here and head into the supinator, where it becomes posterior interosseous nerve, and then we'll exit the distal supinator. Lastly, we'll kind of watch the direction of where that superficial radial nerve goes. So if we watch here, that deep branch has exited, and that superficial branch will start to head up into the forearm. So as we watch here, we can see that deep branch is starting to head down into the supinator, disappears in this view here. And then as we come up to the surface, you can see that superficial radial nerve starting to head toward the forearm there. Eventually, that superficial radial nerve will travel along the radius and will cross over the first dorsal wrist extensor compartment. So you can follow it all the way down to that level if you're worried about a superficial radial nerve issue. So going through that scan, we can see the course of that nerve, and there are 5 potential entrapment sites. We talked about that the radial tunnel is kind of this 5 centimeter distance from the radiocapitellar joint. down to the distal supinator. So there are 5 potential entrapment sites there. You can get entrapped at the radiocapitellar joint itself. You can get entrapped at the radial recurrent vessels, which we saw as they kind of cross over that deep branch of the radial nerve. The medial border of the ECRB also crosses over this area, so you can get entrapped there. The most common site is at the arcata frosh, or the proximal supinator, as the deep branch of the radial nerve becomes the PIN. And then also at the distal supinator, you can have entrapment as well. It's important to distinguish the clinical syndromes that can be associated within the radial tunnel. Radial tunnel syndrome is essentially just pain with compression of the radial nerve, whereas PIN syndrome is going to be pain and weakness. So knowing that the posterior interosseous nerve is supplying purely motor innervation, that's when you're going to get just some of that pure motor weakness with some associated pain. Typically, you don't have any sensory findings, but after reading through some case reports and things, you can have some paresthesias in a radial nerve distribution, but it's not as common. So looking at our pathology in the case that we had, so this is our posterior interosseous nerve as it's between the two heads of the supinator. So you have your superficial or humeral head, you have your deep or ulnar head, and you have your posterior interosseous nerve as it travels between. And that posterior interosseous nerve is very large. So you have hypoechoic fascicle enlargement of that posterior interosseous nerve compared to the nerve scanning that we had seen prior. When we measured that, it was about 6 millimeters squared in cross-sectional area, compared to the unaffected side was about 2 millimeters squared. And looking at kind of normal nerve measurements at the arcata frosh and within the supinator can vary between 1 to 2 millimeters squared in cross-sectional area. So while his unaffected side was, more on that upper limit of normal, clearly the affected side is about 3 times the size of that. Here's a live view of that as it passes through the two heads of the supinator, and you can see that that fascicle starts to normalize as it exits the supinator. So you can see that fascicle enlargement starts to normalize as it exits the distal supinator. Watch that one more time there. So this is a long axis view. So again, in this long axis view, you can see on the affected side that posterior interosseous nerve, clear hypoechoic fascicle enlargement compared to the other side. Didn't see any true notching as it was coming in. You lose a little bit of the fiber there. But you can see it starts to normalize as it exits the supinator. So that brings us to our ultrasound report. So this is a complete diagnostic ultrasound of the right lateral elbow. The indication was right lateral elbow pain and wrist weakness. Our patient was examined in the supine position with a 4 to 12 megahertz linear rate transducer. Our findings, essentially, we had normal appearance of the common extensor tendon, radial collateral ligament, radiocapitellar joint, radial head and annular ligament, the ECRL, and brachioradialis. Our pathology comes with the radial nerve. We want to state that we had a normal appearance of the radial nerve at the mid-humerus and the superficial radial nerve at the forearm. However, there was increased hypoechogenicity with fascicle enlargement of the posterior interosseous nerve within the superficial and deep heads of the supinator, with a cross-sectional area of 6 millimeters squared compared to the contralateral side being 2 millimeters squared. We also saw that same focal enlargement and hypoechogenicity and long axis view within the supinator. So our impression here is hypoechoic fascicle enlargement of the posterior interosseous nerve within the supinator, consistent with focal PIN entrapment. So this case, the outcome of the case, so we sent the patient to physical therapy initially. He had improving pain when we saw him back, but he was still having some persistence of the weakness. Given that his pain was improving, we opted not to do any hydrodissection or any additional intervention for the posterior interosseous nerve. He did come in with a new complaint of left subacromial bursitis, so we were treating that as well. At an additional follow-up, though, he started to have a new complaint of weakness more in an anterior interosseous nerve distribution, as well as some paresthesias and a median nerve distribution. Scanning of the median nerve at that time showed, borderline enlargement within the carpal inlet. But since there wasn't a great explanation for why he had now AIN weakness and PIN weakness, he underwent an EMG, which actually showed denervation both proximally and distally of the median nerve at the pronator teres and APB, and also in a radial nerve distribution on the right at the EIP and brachioradialis. And then again on the left side, a muscocutaneous nerve distribution at the biceps, some acute denervation. So while it did show some carpal tunnel syndrome as well, the EMG was concerning. Is there another process going on that's leading to multiple nerve involvement, both motor nerve and some sensory nerve changes? So we did actually refer this patient to neuromuscular neurology for further evaluation to make sure we're not missing something else, either autoimmune or another nerve pathology. So I think the take-home points from this case is that when we're scanning nerves, I think it's important to do the dynamic scan to watch the course of the nerve and really see how that nerve is heading, look for any signs of entrapment there. Important also to do a side-to-side comparison. You want to make sure what you're seeing is actual pathology and not just normal for that patient. So really comparing to the unaffected side. And then knowing to distinguish the clinical syndromes of radial tunnel syndrome and PIN syndrome, where radial tunnel syndrome, you have more of the pain, but no weakness. And PIN syndrome, you have pain and the motor changes. And then again, knowing that the sites of radial nerve entrapment at the radial tunnel can be, 5 different sites, with the most common being at the arcado-froche, that proximal supinator, where that deep branch of the radial nerve becomes the posterior interosseous nerve. And that's going to be your most common site as well for posterior interosseous nerve syndrome. Keeping in mind too that PIN syndrome can be exacerbated by frequent pronation supination activities is a common inciting factor for that. So I think this was a really good case that kind of walked through some good pathology of the posterior interosseous nerve. Although the case outcome was not typical what we would see for PIN syndrome, I think it really highlights a good nerve scan for this and really keeping a broad differential when you're seeing pathology of the lateral elbow. So I want to acknowledge Dr. Pasculi, who I saw this patient with, who helped with the presentation and kind of getting these pictures together. So I really appreciate her help and all the mentorship and teaching she's supplied to me during my fellowship training. Also to Dr. Schaff, who's been a great ultrasound mentor throughout my career and residency, and it's been great to get to work with him throughout this ultrasound case series. So I have a couple of references here just for some of the normal nerve sizes and some of the images that I used. But otherwise, that will conclude my presentation. Happy to take some questions.
All right, Devin. Awesome presentation. I think a great way to, start out the year on what these presentations should be, going through the thorough, case and all the images that you obtain. And obviously the key is then kind of just, demonstrating a thorough protocol for all these scans, so you just don't, once again, just hone in on the pathology, even though sometimes it can, appear clear. I think just having a thorough protocol, like you demonstrated, is helpful. And then, of course, the report as well too, and describing this. And so, for this case, I think just a couple of things you had already noted that are important for these nerve scans is especially for this nerve is I think ultrasound can really, shine, especially compared to some of the other nerve studies that you can get. Of course, nerve conduction studies are usually, what we're getting for these cases. But unfortunately, as we know that this isn't always the best to kind of pick up this condition. And so then this is where ultrasound can be really helpful. And as you had mentioned, the key is that, for this, you're going to have a side-to-side comparison. So even though we don't have great data currently on normative values and obviously need to continue to grow that for this nerve, it's always, very easy to do a side-to-side comparison to demonstrate that. And as you had mentioned, one, easy thing to do for these, especially is that yeah, some of the still images are, very important, but definitely the cine clips and the video clips of these nerves are usually what will make it very apparent, very quickly. So that's why I always say that initially, early on for trainees, you're kind of just going through slowly, looking at these nerves. But definitely once you've identified it, I think then, making sure you kind of do quips, sweeps can easily identify that nerve enlargement, especially if there's a focal, area of, compression. I think importantly then too is really finding this nerve proximally as well, just because that's when you're going to be able to easily identify the radial nerve, in itself before it branches off, and that of course is going to be larger. So just making sure you feel comfortable finding that more proximally. Otherwise, sometimes you can get a little bit lost as it branches off distally. And then one other thing I'll add in, I think always important for these, nerve conditions is in typically for this one as well too, is that you can get sonopalpation, tennels or tenderness, typically at that location. So usually as you're going through with this, and that's something that I always try to include as well too, that since this is usually going to be about 2 to 4 finger breaths, distal to lateral epicondyle, usually the patient will say automatically, before I'm even scanning over that area and letting them know, oh yeah, that's definitely, the area that I'm getting the symptoms, and then where they're starting to feel any of the pain. Like you had mentioned, there's not always going to be numbness and tingling, with this condition, but a lot of the time they'll be able to kind of focally identify, that area. And then, lastly for this, another thing, obviously, kind of outside the scope of, the diagnostic portion of it. But one thing, obviously, then can be added on to this that I found very helpful is obviously then doing diagnostic injections, for this condition as well, too, which can be extremely helpful to confirm the diagnosis, which I think really at this point is almost the standard, for this condition. And then obviously, if that's effective, then you can start to be thinking about other, interventional injections that you can do. Or ultimately, in some cases, I've had patients that have needed to go on to nerve decompression, at this site as well too. So those are just some of the points I wanted to bring up. But otherwise, great presentation. Just see if any other kind of questions come up for this.
So great job, Devin. That was a great presentation. I think just a couple of thoughts I had on this particular case is one is when I was looking at the nerve, I was walking through tunnels, and so the phone was skipping a little bit, but it looked to me like the nerve was just like very diffusely swollen over an elongated course, not just a focal enlargement. Would that be an accurate statement?
Yeah, I mean, it did, especially, the course within the supinator was a little, thicker as it did go through the supinator and maybe less of like a true notching that you could see.
Yeah, that certainly makes me wonder about like an inflammatory sort of, type condition. I think, like HNPP or mononeuritis multiplex or some of those sorts of things would be a differential for someone who has kind of a unclear um, compressive point for a nerve like this. And if they only have one, nerve symptom, it's hard to justify a workup for something like that. But when it's something looks a little bit kind of out of the typical pattern of like that focal enlargement with return to normal caliber pretty quickly, I'd be thinking about that. And then number two is when you're looking at this nerve, I think, Stephen, you mentioned that the measurements we have are not great. But I think just a reminder that this nerve normally flattens a lot as it enters. And so the cross sectional area does remain relatively stable in asymptomatic patients versus like the diameter of the nerve. And so when we're taking measurements here, just, it's really easy to look at it and long and say like, oh man, that looks like super compressed, but it really is just flattened and it's not necessarily changing in caliber. And so I think just taking those cross-sectional areas like pre-arcade approach, arcade approach, and then within the supinator can help delineate whether there appears to be a compressive etiology there, just related to that notching sort of appearance. It's very common even in asymptomatic individuals.
All right. Well, thanks so much for Brendan for those additional comments. For that case. See if there's anything else that's coming up in the chat. All right. Well, otherwise, I think that will conclude today's presentation. So we'll go ahead and then be meeting monthly for these fellow ultrasound case presentation series for the rest of the year. So we'll see you next month. And thanks again, Devin, for this presentation.